Base, да? Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev, and we are from Presidential National Hospital in Almaty, and we have a patient number 1, 34 years old young lady. She was previously treated a couple months ago in regional hospital in Atrau city, and big aneurysm on pecom artery on the right side was found, and she had headaches, and it was looked like ruptured aneurysm, and we did a first session. On first session we coiled the aneurysm with balloon assistance, and it was small part at the segment of ICA. It was looked like remaining part of the aneurysm, and now we did a control angio, and on control angio you can see there is a something like infundibulum, but it's also could be the remaining part of the aneurysm. That's why we decided to place Elvis Evo stent, and now the plan is stenting of the supraclinoid ICA with Elvis Evo. At the same time, patient has a small meningioma in left front parietal part. I will show you. It was incidental finding, and now you can see on the delayed imaging there is a meningioma. Okay, let's see like this and like this. Patient is scary from the embolization of the meningioma. I think we can discuss with patient. We already discussed with the husband of the patient. It's nearly 1.5 centimeter. And usually with contrast enhancement in 34 years old patient, there is a high risk of meningioma growing. But patient is not ready for the treatment, but I think it's possible to treat this meningioma under local anesthesia without any problem. I think this branch is feeding the meningioma. Maybe something additional could be. Yes, it's possible to do embolization, but let's discuss with patient. If she's scary, then we would not touch the meningioma, and but it's quite close to the sylvian veins, and okay, the head of the patient is a owner of the head, that's why she will decide. And today is 15th of May. My assistant is Suyumbetov Davlet. Davlet is a neurosurgeon. And yes, and maybe we'll close the problem step by step, not in at the same time. Just a second, I will discuss with patient. Тамырларыңыздың бәрін қарадық, алдындағы қойған спиральдардың бәрі орында тұр, артериядан кішкентай жері кеңейген тұр, сол жерге қазір стенд қойып береміз, ол біріншісі. Екіншісі, сол жақтағы менингиома деген ісік бар еді ғой. Сол ісік көрініп тұр, баратын тамыры көрініп тұр. Егер қажет болса, ол жерге де клей жауып кетсек болады. Егер жоқ, пока тиіспеңіз десеңіз, сонда келесі жолға қалдырамыз. Ау, жасап тастай берейік. Все, жақсы, қорықпай жата беріңіз. Okay, we discussed with patient and she's ready for the meningioma occlusion also. And I think we can use headway duo for the meningioma embolization. Lida, can you бересіңші ма? Yeah, yes, 2 ампула 4 мл. We will collect some lidocaine. And we discussed in our group with neurologists and neurosurgeons and radiologists about the treatment risk of parasagittal meningioma. And it was quite interesting that in local questionnaire statistics, сан жерге сквит 12-ден 2 қоя салыңыз. И демосо біз жинаулайық. Ага, 2. It was a quite interesting statistics. Our colleagues said that the complication rate in parasagittal meningioma in frontoparietal region, it's a middle part of the sagittal sinus. The complication rate is nearly more than 5%. It's a local statistic. We need to check the data in publications, and I think it could be surprising. Так, сосын бір headway до 156 мен траксес ашып бересіз, хорошо? Осыдан кейін. Жоқ, ол ар жақта. Okay, it's quite interesting statistics. Қорықпай жата беріңіз, хорошо? Сізді ешкім көрмейді. Қорықпай жата беріңіз. It's surprising. That's why we are continuing the embolization of the meningiomas, and this year I was invited for the brain conference in London to present our experience in meningioma treatment. Yes, we have we have experience in embolization, just embolization, sole treatment of the meningioma with the endovascular technique, and I think it would be interesting for the colleagues. And I asked my colleagues in Astana and in Almaty to collect the data. Экран артқа тарта сал. To collect the data and publish our experience. Nearly half of the meningiomas nowadays we are not touching, and we're just doing embolization and following. And the percentage of progressive growth is not so frequent, and it was just one time when our neurosurgical neighbors in city hospital found one of the patients and said, okay, after embolization there is a meningioma grow, and the meningioma became 3 times bigger, but from the beginning it was atypical meningioma, and in atypical meningioma the effectiveness of even the microsurgical technique is quite discussable, and yes, we can discuss. It's not all the time so efficient. Microsurgical technique, if it's very good results, then why microsurgeons trying to do radiotherapy after meningioma resection in grade 2, grade 3 meningiomas? Yes, everything is comparable and discussable. And for the negative point, they took all those data and tried to show to the young colleagues and tried to advocate that nobody should do the embolization because it's not effective, etc., etc. And it was done by one of the big professors. It's a medical world, and I think it might happen in many places. Stentaş părinți. Turte germobr. Turte germobr. Okay. Now we placed through the 8 French right coronary guiding through the short sheaths, headway 17, and through the headway 17 with the Xeon blue wire. We placed the headway 17 in M1 segment, and now we are waiting for the water from the hub of Elvis Evo 421. Yes, water is coming. Now you can see there is a PCOM just from the neck of the aneurysm here. Okay, let's see here. It's here. It's a PCOM, and this part was the aneurysmal part, and that's why the decision was taken to stent this segment with the Elvis Evo. I think we're correct, and I hope we're correct. This one. Has taught. Sure. Yes, we had some discussion in the morning with the anesthesiology team, and they're quite it was a face of surprise. They said why we are giving dual antiplatelet and a single anticoagulation with the rivaroxaban, and patient has cardiac problems, and with the cardiac problems usually they come with the rivaroxaban, and we are not changing for IV anticoagulation. Usually it's enough rivaroxaban, and yes, they're all the time changing, and I like the practice when you have your own stuff, like in Essen, Professor Chapeau has, and I think in many places it's the same problem. Yes, and we're experiencing the same problem here. Yes, I pushed a little bit more, at the level of the aneurysm to increase the metal mesh density. It's also possible not to push, maybe it will release a little bit, but it's okay, I think. Okay, let's just deploy the... Yeah, just deploy the stent. I agree with Davlet. We'll just deploy the stent. Okay, now stent is opened. Let's go through the stent. And yes, LBS Evo with the braided technology has a good flow diverter effect in the follow-up. In several patients when we had no available FD, we just placed the LBS Evo and it was very effective. And in this case, it should be effective, no doubt about it. Okay. Okay. We will leave this headway. Maybe we can assist for this meningioma. We will put timer and okay. Yes, it's all the time problem with anesthesiology. That's why we start to do nearly all cases. We are trying to do all cases under local anesthesia because of all these anesthesiology problems. But not in all cases the sedation is possible. That's why in some cases we should give a GA. Okay. Let's check the... Oh, it's quite interesting. Okay, stent is opened and fully opposed, and it's a 421 LBS Evo. We will follow that part of the aneurysm, and usually it's not a problem. When it's a small part of the aneurysm, the risk of growing is less. Even it will grow, we can place second stent in follow-up angio. Okay, let's go to the left side. Headway-2. Headway-2 и та бройка нек пробис хостите дали съснаш? И та промивка да инде съснаш? Қорқпай жата беріңіз, стентіңіз қойып қойдық, бәрі жақсы, қазір опықлыға барамыз, жақсы ма? Yes, and one more news, I left my position in Astana. Now I'm working as the chief of the neurosurgical department, not the department, chief of the neurosurgical center in Almaty. I will continue this job, and I decided to take some vacation, and after the vacation we will see. Now I'm free from the formal job. And this time I'm again the physician, not administrative worker. Так, Питесон, нам жала пересер. Бір-бірін жалайсың. Ауыстырсағанда шығар, наверное, или жетеді ма?
Жартысы бар. Так, новый.
Хорошо. Или мынамен ауыстырсақ?
Давай. Сол дұрыс.
Yes, we can. Жоқ, керек жоқ, мына жерден ауыстыра саламыз. Yes, it's just 500 cc line. That's why we need to change it quite frequently. Так, ну, проверим пока. Headway do change?
Yeah.
Yes. Yes, we asked for headway do 156 centimeter, and in combination with headway do, in my experience, it's the best combination. It's effective combination, and we can use less material. With the hybrid and sonic, most of the time, meningeal artery is a killer of the hybrid and mirage. But with the Traxxas is living longer. I think we can go from this. Okay. Yes, it should be more flashing systems. That's better. Okay. It's better visible. It's all the time going in one direction. I think we need to check this branch first. Okay, that's okay. There are two branches of the meningeal artery, the lower branch and the upper branch, and those branches can fit the meningioma. Yes, and today we will live stream for the ICA conference, annual conference in Moscow, organized by Kirill Orlov and team. We are good friends, and it's medicine. It's not about politics. Yes, there is a small branch coming from here. We need to control it. There are several branches going to the meningioma. That's the first, and this branch should be occluded. It's very important to occlude this branch. Okay, let's check the upper. This is more. This branch is most involved. Huh? Smart mask. Так, smart mask вернули. Lidocaine. I will give a couple of drops of lidocaine before the navigation, and then second drop. Now I will give 1 cc. This 1 cc is enough. Пока хватит. Let's flush it. Yes. Солгинге берер. Okay. Демс одинаково, да? Демс одинаково. Okay, I became older and older. I need to look for the instruments over the glasses, and I think it's time to change my glasses. We can place one coil distal to the meningioma branch to prevent the leakage. I think the wire is outside. Yes. When we pushed the microcatheter, it went outside. Okay, now it's better. Алдында ангелом қойсың. Держи. Смарт маска. Стоп. Смарт маска selected. Okay. Yes, it's quite interesting. Usually patients with the meningioma has a very tortuous meningeal arteries. In hematoma cases, it's usually different. Okay, let's place one coil here. Бір спираль бересіңізші? Бір жарым, екі? Бір жарым дұрыс па, екі дұрыс па? Бір жарым төрт бересіңізші? We asked for 1.5 by 4. И отделалкасын бере саласыз ғой. Yes, it will be microplex, 1.5 by 4. Yes, and we are planning to live stream intracranial stenosis cases for the ICAs. And Kirill asked to do stenotic case, and we had this case, meningioma, we had some other cases too, but okay. Yes, It's interesting. There is a lot of technical points. This treatment. I think now it's better. It's okay. Okay. Добре. It's better to place the second coil just after, behind the meningioma, but Просто ходовой он же тут это может быть. Образ. The question is, could we push headway 17 just behind the meningioma point? Okay. Just a second. I will place a second catheter just below the. But it could be better to place. Ана жігіттер өздері түсінбеді ғой деймін да, қай жерге не үшін препарат беретіндер. Аритмия, да? You are not right, no, you are not right. Okay, we're discussing the second patient. The second patient with the, not second, I think she will come third. Oh, no, no. Okay, let's go with the. Yes, the material is in place, that's why I think it's better to have control just below. The micro is not moving, that's good. Yes, it's okay. Yes, it could be a little bit. Tricky. two headway duos is better than one. Huh? It's good. It's coming. I need to push the wire a little bit forward. I think we need to place one more coil here. Okay, maybe no need for coil. We have branch and branch here. Just a little bit below. Let's control from here. Так, опсиса. It's filling, Екі де алты спираль бересіз? Екі де алты. Чайте. Зоя, Adela. Yes, it was Optima 2x6. I think it's a helical. Let's look like helical. Скажи. Джок потяни. There is a lot of collaterals, that's why it's need liquid embolic. You see, it will be like this. Yes, I know it's better. Tabr spiral екі де алты бересіз? I will take one more coil to basics. It's a complex coil, 2x6. The same Optima. Пока отделите ты. Точно. Вот. Пока отделите ты. Yes, we temporarily blocked the flow below, and it looks like there is a shunting. Yeah? Ну-ка назад. Okay. I need to pull. Yes, it's better to go with something small like magic and to occlude this branch. Huh? Okay. I need to pull it a little bit back. Stop. Так, lead okay. Yes, it's at the office. We will do smaller. This direction. Like this, and then we will do like this. Lead okay. Lead okay. Так, даем сакелер. Okay, we will give lead okay. И squid tonic. And then we will give squid 12. Обезболивающее бірдеме бере салсаңшы. На яқтың басын қимылдатып көріңізші. Все хорошо. Я. We took squid 12. I think that's one of the glue. It's from the available instruments, more penetrative, comparing with Aptura. Aptura may be more penetrative, and unfortunately we have no. Okay. Қозғалмай жата тұрыңыз, бір 5 минуттай неприятно болады. Жақсы ма, қозғалмаңыз. Yes, we have a MCA middle meningeal branch, which is very helpful to control the reflux. I didn't detach the coil. It was done specially. Good. If it's needed, we can use the second headway. Назад. It looks like there is one more vessel going to this territory. Назад. Вперед. One more MCA branch is going to this territory. Okay, but it looks like we occluded the feeder, and usually in 2 days we're performing control MR with contrast, and usually it's okay, it's normal. And surprisingly, the branch of meningioma was big, quite big enough, but now we couldn't see the meningioma. Okay, let's detach this coil. Такой detached. Yes, we can put a drop of squid to this point, and then we can. I hope we can finish. Let's wait. Bir 2 kubik lidocain tagib olasiz. Yes, it's not going to the. Going to the tumor. It's going all the time backward. That's okay. Also try to slit. Took it out. Нам рассказать интересно. Демса lidocain. I will put 1 cc of lidocain. Usually we give maximum 4 cc, but I think now it's possible to give 1 more. Демса бересал. Так. I hope it will be enough. It's not visible, huh? It's not visible. Көрінбей қалды, да? It's not visible. I think we need to finish. Yes, there is no tumor anymore. Now, let's check the right side. There is no problem with stent. It's 34 minutes after stent placement. The test is negative, and now we can finish the case. I will ask Davlet to do control CT, and then we can finish. Okay. Just a second. 10:42 қойды. 10:42, 11:42. Аневризма алып жібере саламыз ба? Или стеноз саламыз ба? Жаңа.
Аневризмасы немес қалай? Оған поток па?
Аневризма возможно поток.
Жеңіл не? Стеноз ба?
Стеноз алсақ. Онда айтасың ғой мен қазір. Okay. The second case, patient will come with the cavernous and supraclinoid tandem stenosis. For the supraclinoid, we'll see. Maybe we can use a credo stent. We have some credo stents nowadays, and narrow speed balloon. It was nearly 3 millimeter. Okay, let's see. Which one is better? Biz bәрін бітірдік, қазір томография жасаймыз, сонымен бітті. Қатты ауырып отыр ма? Чуть-чуть болса да ауырып отыр ма? There is no pain, okay. Қозғалмай жата береді. Дөйлеп жалғастыра бер. Okay, dear colleagues, it's a problem as a late machine, old machine. Okay. Okay. It's a problem, huh? Okay. It's as usual problem. Okay. Okay. So how it is. The machine is saying some movement, table movements are not available. Okay, move to the end position by pressing. Yes, the system is alarming about some table movements. We will send the patient for the regular CT, and now we can, I think now we can finish the case. Just a second. Sometimes it won't be. Not all the time, but sometimes it's helpful. It's nicht machen. Ne? That's a problem. I think in all systems it's possible. Okay. Let's see that. Lan суретке түсіріп алсаңызшы. Экран суретке түсіріп алсаңызшы.
Телефон.
Телефон.
Телефон мне включи, пожалуйста.
Экран суретке түсіріңізші.
Вот на другу.
Ана, жоқ аржан. Соны полный түсірер. Okay, we have a video. There is no problem. Record. It's not cerebral, it's expert CT. It's nicht machen, да. Okay. It's not working. Все, мы тренируемся. Сейчас пока систему перезагрузим. Interest трясу. Okay. Okay, we'll finish. Unfortunately, for the last year, time to time, some problems with the machine, but it's okay. We finished. See you in next 25 minutes. Bye-bye. Thank you for watching.